We're going to have the opportunity here to watch Fat Boy Stedman talk about our health plan and how our behavior is changing because now we have to pay for it. He's insinuating that somehow drivers just couldn't wait to get to the doctor to get all of these great rich benefits that we have. Like anybody actually looks forward to going to the goddamn doctor. That's what he's insinuating here. You'll see it at the end of his clip. Yesterday I posted a clip where he talked about the decrease in the rates and how I was complaining about how they got a decrease, but we didn't. Okay, I'm not sure. I'm not tracking on that point of the conversation. I'm running out of time here. I'm supposed to be on a plane tomorrow morning, and of course, I'm not doing what I'm supposed to. I'm still doing this. But he refers to our plan as the platinum plan. If our plan now is the platinum plan, then what was our $5 copay plan? You see, they're using these buzzwords, and you'll see him use the word rich, the richness of the program, he says. That's the richness of the program. And the non-union plan is golden. So that's the golden plan. You know, we don't even have health care like the British and the Europeans and the Canadians, okay? We're getting fucked by this deal. It's just that simple. You know, we had a negotiated contract. They've now abrogated the contract. They're going to abrogate more of this contract. Everybody keeps showing up and pretending they're dedicated. I don't know why. They're fucking you, okay? They're going to fuck you out of your benefit. Who are you loyal to? Those people here? Be thankful you have a job, shit. You know, good for you.
Ad-lib, but we were very pleased with the renewal for the Union Regents plan, which actually was reduced for the first time. Anybody can remember here, the rates went down 3.2%. And so there's a high correlation between the implementation of the new plan design pursuant to the arbitration award and passing on of the rate increase year over year. And those two things occurred basically at the same time, September 1st and January 1st. Utilization of the Regents plan for the Union Regents plan began to plummet. So we took that experience from September 1st to the end of the year in the first 4 or 5 months of 2013 and asked Regents for an early renewal. That's a couple of months earlier than they would normally give it so that we could capture. We were using the correlation between the plan design and the utilization decrease to capture an early renewal before anything else changed. As a result of that, we got, again, a 3.2% decrease on the union plan. The non-union plan was about flat. There wasn't any real changes in the plan design, so we wouldn't expect a great deal of change in utilization, so that was fairly predictable. And then the Kaiser union rates went up around 4% or so, and the non-union went up a little bit more than that. So all in all, very good news, especially on the much bigger union plan. So we were happy with those renewals.
I know my organization is struggling with the health plan and the implementation of the ACA. How is trying to get, I guess, prepared for that, or what's the thinking? If you can share that.
Yeah, the ACA, the biggest change related to the ACA for us is looking forward to 2018 when the excise tax kicks in. Already, our rates, well, many of our rates currently exceed the level at the 2018 level where we will incur excise tax. So we're looking at millions of dollars of excise tax in 2018. Assuming nothing changes, of course, things may change. We don't know. What we do know about our plans is that currently the union plan, according to the ACA metal designation of platinum, gold, silver, bronze, looking at the actuarial value calculator that the government created, our plan for the union is a platinum plan, and our non-union plan is a mid to high level gold plan, and that's what we're proposing that the union have in 2014. So they would, using the government's ACA designation, we're proposing that we go from a platinum to a gold level plan. That will help us with that excise tax considerably. It will also, of course, help us with our OPEB liability. But generally for us, that's the biggest impact. I mean, there are some additional costs associated with the ACA. There's some additional short-term costs, but the big one looming is the excise tax.
Everybody understands the ACA is the Affordable Care Act.
Also called the PAC.
No. Yeah, we received the same news from our unit to excise tax. So, well, thank you.
So the excise tax, is that based on the level of benefit, or you mentioned the rate? I mean, they're both connected in some way.
There's two levels. At the 10,000, I think it's 10,500, 10,000 premium level of 10,000-ish for the single, or 27,500. Anything above that is subject to the excise tax, and it's, I believe it's 40% of it above that. Above that is ceiling. So, as I said, several of our plans in our different tiers, meaning single, spouse, family, and so forth, are already, we know, unless the law changes, are already currently subject to that tax. And as our rates increase between now and 2018, the amount of that tax that will be due will just be increased. So it's several $1 million for us, assuming no changes in the law.
Also, you mentioned that you may have mentioned that there was a decrease in utilization on the Regions plan on the union side.
Yes.
Was there a change in benefits during that time frame that would?
Yes. Pursuant to the interest arbitration award, we implemented what we call the 90-10 plan, which is a change from what we call the $5 copay plan. So that 90-10 plan means that employees have some out-of-pocket costs that they've never experienced before, and deductibles, and the out-of-pocket maximum also increased. So this is the first time that employees on the union plan have had their wallets touched by health care. And so it appears, the data would suggest that it appears that the plan design change and the passing on of the premiums year-over-year pursuant to PECRA has resulted in some behavioral changes. So they are beginning to think more with their wallets, would be what the data suggests. As a portion between the plan design change and the passing on of the premium cost, we can't attribute which had more of an impact. This basically happened at the same time. But what we know is utilization for many years continued to go up, premiums continued to go up, and as soon as those two things hit, it plummeted. And the magnitude was significant of that change in utilization. So I think the data, that correlation, that timing would suggest that people are beginning to think differently. And our plan basically, if you think about it very simply, it costs more to go get a generic bottle of aspirin off the counter than it did to have a prescription filled under the old plan. That's the richness that our former plan had. And so people are seeing that difference and are making different choices. Still a very rich plan.
Continuing on. Thank you, Gary. Thanks, Reggie.